So it's a great pleasure to be giving this talk, though I'm sorry I'm not in Colombia, which is a country I'd love to visit, but one day after this pandemic is over, I'm sure I will get there. It's a great pleasure to talk tonight on the subject of lupus, precision medicine, a topic which has been of great interest to me for many years. My disclosures are here. I have a vision for lupus that better treatment ultimately will depend upon increased knowledge of the etiopathogenesis of the disease, as well as improved clinical assessment. And when we assess a disease like lupus, we have to distinguish activity, meaning ongoing inflammation, from damage, meaning permanent change, not forgetting the patient's perception of the disease, which is often radically different from that of the clinician. Now, the Doris group, headed by colleagues Ronald van Vollenhoven in particular in Amsterdam, has come to a series of conclusions about systemic lupus. That the treatment target should be to obtain remission of the systemic symptoms and the organ manifestations, and that we should try to capture disease activity using validated activity indices and or organ-specific markers. And prevention of flares is a terribly important and also realistic target. It's not recommended that treatment should be escalated in asymptomatic patients. In other words, treat the patient rather than treat the number. But remember that damage, which I touched on just before, predicts subsequent damage and death. So preventing damage accrual has to be a major therapeutic goal in patients with lupus. Factors which negatively influence health quality of life include things like fatigue or pain, and these are very important from the patient's perspective to try to manage, as well as disease activity and damage. Renal disease is very important and very worrisome, and early recognition and treatment of renal involvement is strongly recommended. And for lupus nephritis, after you induced therapy, it's highly likely that immunosuppressive therapy for a minimum of 3 years is going to be required. And lupus maintenance treatment should aim for the lowest possible glucocorticoid dosages to control the disease. In other words, you use steroids for the shortest possible period of time at the lowest possible doses. Prevention and treatment of anti-phospholipid antibody syndrome is very important. 30 to 40% of lupus patients have anti-phospholipid antibodies, and between 7 and 15% have the clinical features that go along with that. Irrespective of other treatments, according to the Doris definitions, consideration should be given to using antimalarials, which are not just good for treating lupus symptomatology now, but also for preventing flares in the future. And relevant adjunctive therapies should also be considered together with immunomodulation, such as treatment to help treat osteoporosis when patients are being given corticosteroids, obviously antibiotics, and antihypertensives. Now, a study of treatment algorithms was carried out by a series of expert evaluations published in Arthritis Care and Research about 5 years ago. And each respondent was sent 16 scenarios and asked to suggest treatments. And algorithms were then constructed and agreement determined as indicated here on the slide. And here in terms of precision medicine, we start to look at individual symptoms and involvement of different organs and systems, because the treatments, although somewhat similar, are also subtly different. So for constitutional symptoms, it was agreed that hydroxychloroquine, low-dose steroids, and immunomodulation, the simple kinds such as azathioprine, may be useful. Second-line treatment will be mycophenolate, and third line will be something like rituximab or belimumab. For more widespread discoid lupus, again, hydroxychloroquine and steroids will fall in the first line. Azathioprine is generally regarded as a better bet for a second line, and that can be switched ultimately, if needed, to mycophenolate or even to methotrexate. Polyarthritis usually responds to hydroxychloroquine and steroids initially, but if it doesn't, then methotrexate can be added in as a second line and rituximab as a third line. Thrombocytopenia, again, often treated initially with corticosteroids. Azathioprine and mycophenolate may be very useful, but I think it's widely agreed also that rituximab, IVIG, and IV cyclophosphamide can be very effective for this particular lupus symptom problem. In lupus patients who overlap with APS, invariably warfarin or low molecular heparin will be the first line of treatment. And then one can, if that isn't enough, add in a number of other drugs, including platelet aggregate inhibitors and aspirin. For neurological problems such as mononeuritis multiplex, cyclophosphamide can be very useful even as a first-line drug. For second-line, rituximab or IVIG or even plasma exchange has been used to treat some people. For nephritis of the proliferative variety, steroids and mycophenolate, first line, intravenous cyclophosphamide, second line, and that can be switched with or added, rituximab can be added to. For membranous nephritis, again, steroids and mycophenolate can be added as first line, and that can be switched to azathioprine. Very important when patients are women, because clearly azathioprine can be given during pregnancy, but mycophenolate cannot be, or cyclophosphamide or rituximab. Now, the understanding of lupus is very important in terms of its etiopathogenesis. And in order to understand that, we have to understand the process of apoptosis. First defined some 40, 50 years ago, and it also explains one of the key mysteries of lupus, which is why patients with lupus develop antibodies against structures buried deep within inside the cell. As you can see from the slide on the right-hand side, apoptosing cells see a condensation of nuclear material which gets to the surface of the cells. And under normal circumstances, apoptosed cells are very efficiently removed. And this was a beautiful piece of work done in Baltimore some 25 years ago, in which human keratinocytes were subjected to ultraviolet radiation. Apoptotic cells were formed as a consequence of the ultraviolet light. There were larger apoptotic blebs, which contain things like nucleosomes and the larger rho particle and LAR and SM, and the smaller blebs, surface blebs, included the smaller rho particle, ribosomal P, and a number of other interesting antigenic targets, such as JO1. Now, under normal circumstances, removal does not happen. This complicated process also involves the C1q receptor and a number of heat shock proteins. And a consequence of the failure of the efficient functioning of phagocytes, fragments of the nucleosomes, the DNA and histone, get into the circulation, and as a consequence, antibodies are formed against them. Now, about 10 years ago, it seemed that we would find a number of different targets for lupus therapies. We were going to use precision medicine against particular individual cells and molecules. And here are a number of suggestions for the way that we thought we would be going. And one of the great disappointments in the past 10 years has, as many people will know listening to this talk, has been the failure of so many different approaches. Very, very disappointing. So I put this slide together some years ago, and it was, as you can see, pretty depressing. Using rituximab back in 10 years ago, the Explorer study of non-renal lupus and the study of renal lupus, the LUNA trial, both failed to meet their endpoints, although some clinical and serologic benefits were noted in post-hoc analyses. Using an anti-CD22 molecule, epratuzumab, we had 2 failures. Using abatacept combined with either mycophenolate or cyclophosphamide also resulted in failures. Now, when you put together a slide like that, you become pretty depressed. And when you become depressed, I think you might turn to an antidepressant. I, however, turn to music. And the song which I thought of as I wrote this slide out was, of course, Elvis Presley's Heartbreak Hotel. But I think Elvis, if were to join us in the room today, would not be singing the original words of this song. Rather, he'd be saying, well, those lupus trials failed. Another one bites the dust. The wolves of hell are waiting for me in the Heartbreak Hotel, where I'll be in good company. Yes, in good company, and so depressed because my patients could die. But ladies and gentlemen, there is better news. At last, there is some better news. We've seen some advances in the use of belimumab, for example, which blocks the BAF B-cell activating factor. Both the BLISS-52 and the BLISS-76 studies met their primary endpoints, and as a consequence, this drug or this approach was approved by the FDA some 9 years ago and was approved in the UK by NICE approximately 5 years ago. In contrast, another anti-BAF antibody, tabalumab, met its endpoints in one clinical trial, but not in another one. And a third anti-BAF antibody did not ultimately make it in its phase 3. Atacicept is still with us. This blocks 2 B-cell activating factors, BAF and APRIL. There were problems with the first trial, but we now have good evidence that certainly serologically significant benefits can be accrued, and we suspect that clinically that will also prove to be the case. And here is the data to show you the BLISS-52 study, which shows the comparison between belimumab at 1 mg per kg, sorry, let's go back, compared to the placebo, and the belimumab at 10 milligrams per kilogram, where you see a p-value even stronger. And the BLISS-76 study, that very strong correlation with belimumab at 10 mg per kg was confirmed. And we now have a third trial, which was carried out in the Far East, published 3 years ago by Zhang and colleagues, showing in the blue the response to belimumab using the SRI-4 over on the top left here. Using the Selena-Celiac 4-point response, you also see improvements. And these improvements start relatively early, from about week 8. And as you can see, are consistent and remain all the way through. And the time to severe first flare also better with the belimumab Benlysta treated patients. And more recently, we've had some renal studies, which has also shown that Benlysta has been effective. So we now have 4 clinical trials showing that this targeted approach, blocking a B-cell activating factor BAF, is effective. So the update here is that, as I've said, it was approved for use by the FDA 10 years ago, approved by NICE. Long-term studies importantly have shown that this is a safe drug with benefit in up to 2/3 of the patients. And as I've mentioned, it met its endpoint in a trial of lupus nephritis much more recently. Another very important biologic approach, which I'll be coming back to, is the importance of blocking interferon alpha. Interferon alpha, as I will show you, has a very important role in the immune response, and we'll come back to that in just a moment. But I wanted to go back to rituximab. I must confess I have a great interest in rituximab, as I was the first person to use it in the treatment of lupus 20 years ago. So B-cell depletion, which is what rituximab is really all about, is recommended by the ACR and EULAR guidelines for the treatment of lupus nephritis. It's approved in the UK by NHS England. It is widely used for many aspects of lupus, but this is not a cure. None of these things are cures, and it's clearly of no help to approximately 10% of the patients. And you have to be aware with its longer-term use, hypergammaglobulinemia and allergic responses can be a challenge. What I think is fascinating about rituximab, and again gets back to this point of precision treatment, is that it seems to work in a slightly different way in different organs or systems. We've seen some dramatic responses to anemia and thrombocytopenia within 2 weeks. Arthritis, pleurisy, pericarditis take a little bit longer, 1 to 2 months. Skin involvement is variable, I'll come to that in a moment. Renal disease may be prolonged by several months. So here are some examples of where B-cell depletion has been very helpful. On the left-hand side, we see a patient with lupus whose subacute cutaneous disease had been started about a year ago. And what you're seeing now is the patient as she looked after a year on an average of 40 milligrams of steroids, 40, 6 months with azathioprine, 6 months with methotrexate. Pretty awful. She came to see me in 2003, complaining bitterly about her appearance and asked if I could give her this B-cell depletion, which she'd read about. We did. And 4 months later, she looked enormously better. Interestingly, she had a flare about 3 or 4 years later. We'd retreated with rituximab, and she's done equally well and has remained in remission ever since. This patient was from Slovenia originally. She was living in England, married to an American serviceman, living in Lakenheath just outside Cambridge. And this looks pretty terrible. And this is after 2 months of treatment with steroids. And I think just a week or two on azathioprine. And you can see also the loss of hair on the top of her head and the marked malar rash. It's a very active alopecia. 3 months after treatment with B-cell depletion, which we managed with a combination of rituximab, low-dose cyclophosphamide and steroid, she looked enormously better. In the kidney too, we can see major differences, but here's the skin data. And I want to highlight the fact that you see some differences in particular, both acute lupus, acute cutaneous lupus, and non-specific lupus seem to be much better in terms of their response to B-cell depletion than subacute cutaneous lupus or chronic cutaneous lupus. And these are the kidney appearances that we've seen on a number of occasions. These slides provided to me by Professor Van Vollenhoven. On the left-hand side, you see a patient with diffuse proliferative disease. 8 months after treatment, you can see a vastly improved looking kidney. And it's not just in my centre at University College London that we see this improvement. This is a national study organised by Ian Bruce and colleagues at the University of Manchester, 178 patients with 6 months follow-up, and a 55% response at 6 months from centres right across the UK. So there's no doubt, I think, that B-cell depletion is an effective way to go in many patients with lupus. What we now need, of course, is some guidance, and there is some encouraging data which is being released, discussed actually at the International Lupus Conference, suggesting that a combination of urinary biomarkers and possibly serum biomarkers, together with some clinical factors, will provide us with an algorithm which will help to predict, again, that precision aspect of medicine, to predict which patients are more likely to respond to rituximab. Now, my colleague in London, Liz Lightstone, who's a nephrologist, works at the Hammersmith Hospital, said to me in the early 2000s, you know, if this B-cell depletion is working the way that you've been using it in England, in London, in your centre, towards the end of the lupus journey, which is where we were allowed to first use it 20 years ago, I'd like to use rituximab at the beginning of the lupus journey, when the patient has just been diagnosed. And my main aim will be to try to stop using steroids. And so she developed a protocol in which patients under her care get 2 shots of rituximab, followed by mycophenolate and hydroxychloroquine. And the results published 8 years ago now were very impressive. As you can see, at 1 week, 50% of the patients are in complete remission. And if you combine complete and partial remission, over 80%, nearly 85% of patients are in complete or partial remission using no oral steroids. And considering that these drugs, steroids were first introduced for the treatment of lupus back in 1950, this is really quite a sensational result. I want to point out that we're now moving to an era where there are different sorts of monoclonals available to block CD20. Rituximab is what is called a type 1 CD20 monoclonal, and I want to highlight the importance of obinutuzumab because I'll be coming back to it in just a moment. There's some very important differences in the way these two drugs redistribute CD20, in their complement-dependent cellular cytotoxicity, and the capacity to induce apoptosis. And there are good reasons to believe, based on some work done by my colleague Venkat Reddy, that obinutuzumab is going to be more effective at getting rid of CD20 positive B cells. But let's flip back to the use of interferon alpha. And to remind you that interferon alpha, as you can see from this slide, is at the center of a great hub of interconnected molecules. So blocking interferon alpha was thought right from the start might be a useful way to go in patients with lupus. And to remind you that some of the drugs like anifrolumab actually block the receptor, while others like siflimumab or montalizumab are blocking the interferon alpha itself. But it's the anifrolumab which has really come out best in the trials that have been done so far. Just to remind you that the two composite indices which are used in these clinical trials are the SRI-4, or the SRI, the SLE responder index, which is a composite index utilizing an improvement of 4 points or more on the SLEDAI system, no new bileg A's, but you're allowed one new bileg B, and no increase in physicians global beyond 0.3 centimeters. In contrast, our BICLA response shows improvements in all domains affected at baseline as assessed by BILAG 2004, with no worsening of other BILAG scores and no worsening of the CA2K or the physician's global, and no initiation of non-protocol treatments or use beyond protocol allowed threshold. So these two composite indices, SRI-4 and BICLA, have been widely used in the clinical trials which have been carried out recently. So here's one example, let's go back, where we compare the standard of treatment plus anifrolumab together in 1 or 2 doses, or the standard of treatment plus the placebo. And what's very interesting, and it was again suggested of precision medicine here, is that in patients who had a high level of the interferon message, you can see there was a highly significant difference between the patients responding given either placebo against background compared to patients given the anifrolumab at the 2 dose levels. Both at the primary endpoints and for the secondary endpoints, we saw some very encouraging results. So this suggested to us that this might give us an element of precision. In other words, we would perhaps want to use anifrolumab in patients with a higher level of the message. That, however, has not been entirely borne out by some of the bigger clinical trials, the TULIP-1 and TULIP-2 trials, which I'll come to in just a moment. But here's a very nice example of how the BICLA response in that interferon high group on that in the graph down here on this left-hand side, you can see fantastic differences, deltas of 20% virtually between the anifrolumab treated and the placebo treated group of patients compared to the patients who had the interferon low message. So putting this together, although TULIP-1 did not meet its primary endpoint, which was actually SRI-4, TULIP-2 met its endpoint using the BICLA as a primary endpoint. And when you analyze the TULIP-1 and TULIP-2 data together, it appears that anifrolumab is particularly effective in patients with skin disease and high levels of interferon message, although that hasn't been completely confirmed yet. But excitingly, anifrolumab has been approved by the FDA. Now, there are a number of other possibilities being investigated, and in the case of voclosporin, have now been approved by the FDA. As I've hinted, we're looking very hard at fully humanized anti-CD20 molecules. I've touched on the subject of atacicept, which blocks 2 B-cell activating factors. Dapirolizumab blocks the CD40 ligand. Some early data suggests that might be effective. Antibodies to the Fc gamma 2b, known as SM101, looks quite interesting. And there have been some attempts to use the JAK-STAT inhibitors, including ibrutinib and baricitinib. Other attempts to treat lupus have been based upon a T-cell peptide, which is influencing T-cell function. Low-dose interleukin-2 has been used, and an interesting peptide known as lupusol blocking autoreactive T-cells has also been used with some early encouraging results in phase 2, not mirrored, unfortunately, in phase 3. So let me try to draw some conclusions from the data that I've been showing you this evening. It's very clear, as many of you will know, that the mortality from lupus has improved significantly in the last 50 years. We know, for example, that in the 1950s, the 4-year survival of patients with lupus was about 50%. It's now about 85%, 15-year survival. And on the face of it, that sounds very good. But remember, what that's also telling us is that if you're age 20 and you get a diagnosis of lupus, there's still a 1 in 6 or 1 in 7 chance you'll be dead by the time you're 35. And that's obviously not so good. And of course, that doesn't even allow for morbidity. That's just talking about mortality. We are, however, moving from an era of serendipitous descents, introducing new therapies on a far more rational basis. And ultimately, we will try to tag particular approaches to particular types of lupus. But unfortunately, the successful use of the biologic drugs that we've seen in rheumatoid and psoriatic arthritis has not been replicated in lupus. We are at least a decade behind our colleagues in treating those diseases. The early open label success of rituximab was not followed by clinical trials which met their endpoints, although it is widely acknowledged that rituximab does work for many patients. As I've said, it's approved by the ACR and the EULAR lupus nephritis committees. Benlysta has met its clinical endpoints in 4 different clinical trials. It's a very safe drug. Although its onset of action is a little slow, it clearly is an option for patients with skin and joint disease in particular. And as I said, very encouraging results have emerged with atacicept, but even better voclosporin and interferon alpha have both been approved for use in the United States. But more careful thought needs to be given to the design of clinical trials. I think it's true to say that there's very good reasons to believe that many of the earlier clinical trials were not very effective, not least because of the very high levels of background medications that you treat patients with in these clinical trials. I haven't had time to talk about it tonight, but the first combinations of biologic drugs in lupus have been reported. In the Beat Lupus trial, which is a study of some 55 patients, an investigator-led study, which was started in my own department by my colleague Michael Ehrenstein, all 55 patients were treated with rituximab. Half of them were given Benlysta to follow, and half of them were not given Benlysta. And the primary endpoint, which was the reduction in DNA binding, was met, and some very other important clinical features, including reduction in the number of severe flares, was also met. So the other point that's, I think, very important is to consider the use of biological therapies in lupus patients at the time of diagnosis. That needs to be better tested. So lupus remains a highly diverse, very challenging disease, and attempts at precision medicine in its treatment remain, I'm afraid, aspirational rather than actual. So if I want to sum up where we are with lupus treatment, I'd have to say it's a question of past imperfect, future tense. And my thanks to many people, because the data I've described to you coming out of my own group would not have been done without the help of many different people who I'm very anxious to thank this evening. Thank you for listening.